Thank you, Dr. Blumenthal. I appreciate the introduction. So I have a list of slides, and if anybody can't hear me or have any questions, please just speak and interrupt because I cannot see both the Zoom and my slides at the same time. So I wanted to give a little bit background on what is going on with syphilis in New Jersey and a little bit of national picture as well as talk about some of the challenges and some of the hope we have on the horizon. So when we say STDs are on the rise, I have the middle numbers or the first numbers to the left are what's going on in the United States, and then I have what's going on in New Jersey. So I kind of want to take away from here is we're not alone in what we are seeing. This is happening across the country. We are seeing a decline in chlamydia, mainly because during the pandemic, it really interrupted routine healthcare visits. And with that routine healthcare visit interruption, routine screening also was interrupted. And as you all know, chlamydia is mostly asymptomatic. And so when we have a problem with our screening program, we then don't get as many cases. We did not see the same trend with gonorrhea, as you all know. When there's discharge or burning with urination, people will seek care. And so we've been pretty steady between 9 and 10,000 cases, depending on which year for the last couple of years. Where we've seen a huge increase across the country has been in our syphilis and our congenital syphilis diagnoses. When I look at our congenital syphilis diagnoses by different states, in 2014, as you all can see, there were very few states, Louisiana being the most, having 33 to 72 cases. Flash forward to 2023, it's very hard to find a state that doesn't have more than 33 congenital syphilis cases. This is a rate, so 33 syphilis cases per 100,000 live births. In New Jersey, we have roughly 100,000 live births each year. So our rate is also our case count, and we are looking at about 49 to, well, we're going to go with 49 cases in the last couple of years. We started to really see an increase start coming in 2016. There were a few cases before then, but when we really started to see it pop up, we started to look at what were we doing, where were they coming from, and what was happening. In 2016 through 2019, we were doing grand rounds whenever a hospital was detected. We were reaching out to the OBGYNs, to emergency, and doing education to make sure everybody was aware. In 2020, you all know we had our pandemic come and we jumped to 24 cases. What I really want to emphasize here is that before the pandemic started in March of 2020, we had already had a dozen congenital syphilis cases in the first 3 months of 2020. I can't blame the pandemic on the fact that this went up. It really started before then. After we got really solidified into the pandemic, we saw our next big increase up to about 49 cases, and that's where we've pretty much stayed for the last couple of years. Preliminary numbers for 2024, we will have 49 congenital syphilis cases. And again, because we have about 100,000 live births, our rate is also our case counts. When we're looking at our different syphilis diagnoses, as you all are aware, primary and secondary syphilis is also infectious syphilis. This is what is most likely where people are transmitting to others. Our early non-primary, non-secondary syphilis, we have evidence that this person was negative in the last year, whether they had a documented negative RPR, they have a partner presenting with symptoms of secondary or primary syphilis, or they have a rise in their titer because they're reinfected. And our late latent cases, these are the individuals where we cannot prove that they were infected in the last year. They are recommended to be treated with 3 doses of Bicillin and treated as late latent. I do believe some of these are probably early non-primary, non-secondary. I can't prove it, so I got to count them as late latent. What you can see here is that in 2012, we went from having 229 primary and secondary or infectious syphilis cases, peaked in 2022 with over 1,000 cases, and are back down now in 2024 to just over 700. We see the similar trends for both early non-primary and late latent as well. I will say, and I probably have it somewhere else in my slides as well, When you're looking at 2022 and you're seeing the peak in 2022, I would also remind everybody that this is also when Mpox or monkeypox was first being diagnosed. And during that time, we were also looking at the co-messaging of if you think Mpox, test for syphilis. If you think syphilis, test for Mpox. And I really think our New Jersey providers did a great job of listening to that message and testing for both. And I think that's probably one of the reasons that I would attribute to seeing a decline in cases is because they got so much testing and treatment done, as well as a delay due to Mpox scare of people having new partners. Looking at it by county across New Jersey, I'm hoping people can see my mouse, but this is Mercer, this is Essex. Essex County with the city of Newark has the most cases in the state. In 2019, they had 191 early syphilis cases, so that's primary, secondary, and early non-primary, non-secondary. Peaked in 2021 with 287 and are back down as well. We also in 2021 had initiated some extra procedures in Camden and Union County because the increases we were seeing there had us very concerned. And we're happy to report both of those are going down as well. So after a little data, I want to talk about some of the exciting stuff that is on the horizon. For those of you that are not aware, the new kid on the block is called DoxyPEP. As you all know, doxycycline is quite old and one of our well-known drugs. PEP stands for post-exposure prophylaxis. And so there has been a study that was done out of Seattle, Washington, and San Francisco, looking at taking 200 milligrams of doxycycline within 72 hours of having sex. And what does that do to your STD rates? They had to stop the study because the STD rates were so low in the case arm that they said they have to stop this for ethical purposes and offer this to everybody. That was enough for CDC to recommend discussing DoxyPEP with all gay and bisexual men, as well as transgendered women, given the fact that that was who was included in the study. There has been a study in Africa that was done with heterosexual men and women. Unfortunately, it did not find results. I'm hoping that they will be repeated and the recommendation will be expanded in the very near future. So the results that were coming out of San Francisco, and this was recently presented at the CROI conference for the Conference for Opportunistic Infections, very much a heavy HIV conference. And this is what's coming out of the San Francisco City Clinic. And so they had two arms, and they were looking at a CBO or a community-based organization sexual health clinic compared to their governmental or municipal-based sexual health clinic. And both found significant declines in chlamydia and syphilis, upwards of a 90% decrease in chlamydia cases and 56 to 78% decrease in syphilis cases among those who were taking DoxyPEP compared to those who weren't. They did not find a significant decrease in gonorrhea, which I'm not really too surprised at. The CDC estimates through the gonorrhea gonococcal isolate surveillance project, which takes and looks at the resistance patterns that are currently circulating for gonorrhea, has roughly about 30% of cases are resistant to gonorrhea. So I'm not surprised to see that it was somewhat beneficial, but not as beneficial as it was for chlamydia and syphilis. San Francisco then went and looked further, and they said, okay, after they showed the two clinics for their CBO and their municipality clinic and said, we have great results here. The next thing we want to look at is let's issue a citywide policy saying we're recommending DoxyPEP for everybody. They were ahead of the curve before CDC got their recommendations out. They put out theirs. And then they looked at it to say, okay, what's our trend of chlamydia on the left and our trend of syphilis on the right before we implemented our policy change? And you can see November of 2022 is when they implemented their policy change. And then they looked to see what happened after. And what they saw in a citywide, regardless of who had DoxyPEP and who didn't, a 50% decrease in observed chlamydia cases and a 51% decrease in observed syphilis cases. So DoxyPEP, one of the things when we look at some of the HIV biomedical interventions, they're very expensive because they're new drugs. Doxy's been around forever. So very cheap, very affordable, and not having to take it every single day. There's not the GI issues as they were seeing when they were recommending the prophylaxis be take a pill every day. Too many people had GI issues with that much exposure to Doxy. So we're very, very fingers crossed, and I really hope that we can push this message out to all of our providers and make sure that DoxyPEP is in use. So one of the other really big items that we have been pushing since 2021 is what we call FEMUR. FEMUR is Fetal Infant Mortality Review, and there is an HIV arm. As you all know, we should be able in 2025 to prevent maternal to baby transmission for HIV. We have all of the information in play. We know what needs to be done. We wanted to expand this beyond just HIV exposures and look at syphilis as well and say, how can we work syphilis into the same review process in which we can do an intensive data gathering, including a maternal interview that's very in-depth, present this to a case review panel that is made up mostly of doctors and nurses to review a de-identified case and see what happens. Look at what community, bigger, larger group coming together saying, where could we have implemented changes, especially as Dr. Blumenthal brought up within social determinants of health, and how could we all work better together? And then how can we add those systems of change to our organizations in order to prevent future cases? So a lot of this is looking at where were missed opportunities. What could we have done to prevent this case? What issues do we see as commonalities among all of these individuals? And then how can we work to facilitate community action? What was very clear is we're not here about fault finding or assigning blame. We mask what hospital these cases come from. We don't have patient name. And so a lot of times we'll have, I think that's my case. And it's like, we don't know whose case it is because we're not here to find blame. We're here to try to look at the whole problem and fix it from there. So some of the data from the cases we've reviewed thus far, which I want to say at this point is probably in this data is anywhere from 40 to 50 cases. Most of them are syphilis because we have more congenital syphilis cases than we do HIV exposures, especially HIV exposures to women who have detectable viral loads. And then we have a few that were co-infected as well. So most of the data I'm about to show you are among congenital syphilis cases to understand what's happening within that population. So when we look at the age of the mother, what we're seeing is pretty much across the gamut. Yes, I have a 14-year-old who not only had a baby, but also found syphilis. And so it's kind of across the board for us to work with all different age groups for the mothers and looking to prevent congenital syphilis transmission. Looking at our race and ethnicity, most of our cases identified as Black non-Hispanic, the next largest group being those who are white non-Hispanic. Spoken language, most spoke English, next highest was Spanish, and then we had some French and Haitian Creole mixed in as well. Insurance type, and so looking at the insurance type of the mother, 81% were covered by Medicaid and 14% were uninsured, which ultimately means the baby would have been covered by Medicaid as well. Very interesting as well is looking at prenatal care. So as you may be aware, in New Jersey, it's required by law to test at first prenatal care visit and then again at delivery. We do not have a law in New Jersey that says you need to test at third trimester. However, the New Jersey Department of Health has put out a health alert every year since 2018 that I'm aware of, suggesting that we strongly recommend screening in third trimester. This year, ACOG, the American Academy of Obstetrics and Gynecology, they also put out recommendations to say that they highly recommend screening in third trimester as well. When I look at this and I could see where we're at, 31% of our mothers had no prenatal care. That is, they walked in at delivery, never had seen a doctor. We couldn't find any evidence of prenatal care, no matter where we looked. The next highest group is our inadequate prenatal care. That is, they began prenatal care in third trimester. I can tell you a lot of the cases that I have reviewed, they're starting their prenatal care within 1 month of delivery, which, if you know, in order to treat the baby in utero, mom needs to have started the Bicillin dose 30 days before delivery. Most of these women are coming in well within 30 days of delivery, meaning we have no time to prevent the case. When we asked and talked to the moms or looked through their records, we found that 40% of them had had an ED or an emergency department visit during their pregnancy. 50% were actively using substances, and several were polysubstance users. So looking at heroin and morphine and opioids, the whole gamut, we were seeing it. 38% had been part of a substance use treatment program, and 50% had some involvement from DCP&P and had some knowledge or interactions with them as well. So I wanted to share for everybody here that this is not just, what New Jersey is doing across the country. As I showed, everybody's seeing a huge increase. And in fact, CDC has been putting out that some of the syphilis numbers that they're seeing mimic those of the 1940s and 1950s, which is just crazy to think that that's where we're at today. CDC had put together an MMWR looking at missed opportunities for preventing congenital syphilis, and I left this here for you to look at. But they were also finding that any healthcare encounter during pregnancy was an opportunity. So they were seeing people visiting emergency departments, jails, maternal child health programs, syringe service programs, and the thought is, if we could have tested them at any time, would that have given us what we needed to try to prevent that case of congenital syphilis? I can say as well that there is a hospital, Cooper in South Jersey, who has implemented a policy where when a pregnant woman comes into the emergency department after, I believe, forgive me, not a clinician, but after a certain number of weeks, they're taken to labor and delivery, and that's where they're seen. Labor and delivery is now checking and saying, if we don't see any prenatal labs in our system, we're going to pull the blood, because if we just get the test, your local health department is here to help you follow up on the case. I think sometimes our emergency departments are hesitant to screen because they don't want to do the follow-up. That's what your health department's here for. I need everybody to test. If they get tested, they're going to end up in my system, and then I'll be able to do the follow-up to make sure we can prevent all of the cases we can prevent. So some of the trends that we saw through our FEMA review, we had some gaps in coordination among healthcare providers. We have patients who are going one place to get tested for STDs, one place for their prenatal care, and then the third is the delivery hospital that's not connected to their prenatal care, and there's not great communication to understand what happened here. There's gaps in testing. Most of the tests, I would say, is being ordered for the most part, but we have women walking around with their orders to LabCorp in their purse and never actually get them filled. They have multiple visits. They've got 3 or 4 orders sitting in their purse, never have gone to LabCorp and gotten them filled. And so missing all of those testing, even though they're ordered, they never got resulted. There's some gaps in treatment and care. I think a lot of people are hesitant with syphilis. They're not 100% sure. If you ever have talked to me on the phone about a syphilis case, my first question when I find out it's a female, I said, is she pregnant? Because if she's pregnant, I'm going to change every single one of my recommendations. I err on the side of caution. I'm going to recommend get a dose of Bicillin in her. Let's not wait, because the longer we wait, the less likely we are to prevent that case. As you saw before on the slides, about 50% of our cases have active substance use. That's been a barrier. Also, mental health issues and diagnoses, definitely a barrier into engaging in care. And then I think there's also some gaps in community knowledge, people not understanding what is syphilis, what needs to be done, and just being able to increase the knowledge of what is syphilis. So our next step of our femur is to go to our community action team, which is a much larger group comprised of various entities, state offices, uh, the Hospital Association, various hospitals, our Ryan White program. Everybody tries to sit at the table and say, what could we do differently? So they have a four-pronged action plan looking at training and education, outreach, policy advocacy, and resource development. And so looking at the training and education part of it, we have worked with the New York City Prevention Training Center to have a statewide congenital syphilis update. We've also had some webinars during our STDI Awareness Week, which is in April every year. We've worked with Rutgers Francis X. Beauregard Center and the Partnership for Maternal Child Health to have a webinar looking at substance use in pregnancy to raise congenital syphilis awareness among the persons working with pregnant women to make sure they have all the services they need. And then we've also worked with our AIDS Education Training Center, or AETC, to have a webinar as well to look at the outcomes and findings from our FEMA review board. For trainings, we've looked at, we have provided trainings for substance use treatment programs, including the Mommy and Me programs. And we've been utilizing the data when we look at where cases are coming from. We're trying to reach out to those hospitals in order to say, hey, can we do some grand rounds with your OBGYN providers? Can we do some grand rounds with your emergency department providers? We think it's really important to just increase awareness of syphilis. It's back, it's up. Here's what you should know. For outreach, we have worked with our regional educational committees for the maternal child health, which is comprised of hospitals, nurse educators, working with, I think, the perinatal risk assessment, also known as the PRA, making sure to put the right questions in there so they're being asked. We've worked with New Jersey's chapter of Obstetrics and Gynecology Council, making sure that they're aware and being able to share messages with their group. We've also had a close relationship with various substance use treatment facility medical directors. We are invited to their quarterly calls. We're raising awareness of, hey, syphilis is on the rise, congenital syphilis, here's what should be done. And we also work with our federally qualified health centers, as our FQHCs often see a lot of our population as well. For policies under our Department of Human Services, our addiction services is looking at how to integrate STI testing and prenatal care linkage into their substance use treatment programs. And very encouraging is the grant language coming out for what the federal government is giving to substance use has basically said, please start making sure to integrate your HIV and STI testing into your programs. And so that's helping us with that argument of saying this is why we need to do this. Rutgers FXB is also working with their government affairs, looking at legislative opportunities around our syphilis testing laws. Unfortunately, New Jersey Department of Health is not allowed to comment on pending or upcoming legislation. Again, these slides will be made available. I wanted to make sure to give some self-paced learning, looking at with CME credit from the New York City Prevention Training Center. They do a really good job. I would also encourage everybody to know as well, part of the New York City Prevention Training Center is they do have a clinical consultation network. So when you run into that syphilis case that is just really odd and something's not going right and you're trying to figure out what should I do, the clinical consultation network is very good of STI doctors who really only work with syphilis and HIV, and they usually are able to say, hey, this is what you should do in this situation. So it's a good resource to have at your fingertips as well. In our work with Rutgers and the New York City Prevention Training Center, we have put out some handouts and some information. There's been some billboards across the state. I hope you guys have seen them, in which we're just really trying to raise awareness and make sure people are aware. We're really trying to push this message of, test, get testing. It's so important, get testing. So we're hoping that as we see more testing going on, we can prevent more cases. So I want to switch gears a little bit off of femur and talk a little bit about the cost of Bicillin. I'm not sure if this has happened to any of you here, but I'm sure your colleagues, many of your colleagues would have this happen. You have a really good patient. You see them all the time. They never skip out on their appointments. You give them a syphilis diagnosis, and all of a sudden they start ghosting you. They haven't showed up for any of their appointments. They're not calling you back. And you're like, this is not right. This is a good patient. A lot of times what we will tell our providers when we call is say, hey, if that happens, call your patient and leave a message and let them know if you just got hit with a big copay for Bicillin, call us. We have a way around that. We have patients telling us it's anywhere from $350 to $1,500 for a single dose of Bicillin with their insurance. I have no idea why. I really wish I understood why it was so expensive. However, it is, and this is what we do. Part of New Jersey Department of Health, because we received federal funding that was allocated under the Public Health Services 318 funding, we are eligible for 340B pricing. That is a discount that the drug companies give to public health in order to make our dollars go further. Right now, the cost to me to buy a single dose of Bicillin is $1.80. So there are strict rules we have to follow. And so usually what will happen is I will call you, the provider, and I would say, Dr. Blumenthal, your patient needs treatment. They can't afford it. What's going to happen is I'm going to come in, I'm going to hand the medication to the patient. Where they get it administered, they don't care. So the patient can then hand it to the Dr. Blumenthal and he can administer the dose and we're all good. The problem is I have to give it to the patient and make the patient in our records as he was our patient. So we have standing orders from our medical director to give Bicillin to anyone diagnosed or exposed to syphilis. And again, where they get that medication administered, it's up to them. So one of the things I want to make sure to take away today, if you hear of anybody having trouble getting Bicillin, there's a phone number there. You call and you say, I have a patient that needs to get treated. I need some help with Bicillin. Somebody will help you. And in an emergency situation, our STD director is Toby Levin. You email her and let her know, hey, I need some Bicillin. She will get back to you on the next business day, 100%. So I said I don't know why Bicillin costs so much, but I have some ideas as to why it is. As you also might have known, in the last 10 years, there have been 2 Bicillin shortages. The first happened because Pfizer had a contamination in their line and had to throw out all of their product. And the second one happened because there was a huge demand and an increase. And as we'll show you now, the process of making benzathine penicillin G, or Bicillin as I'll call it, is not an easy one. So the first thing that you need to know about making Bicillin is what you need to make Bicillin is an active pharmaceutical ingredient, which is the penicillium. As of 2015, 2011, actually, there is only 3 places in the world that is still creating the active pharmaceutical ingredient. And those are 3 facilities in China. In 2019, Spain opened up a plant in order to create the active pharmaceutical ingredient, but right now they do not produce that much. The 3 major producers are the first 3 listed on this list. There is no active pharmaceutical ingredient being created anywhere else in the world. That active pharmaceutical ingredient, again, 95% is coming from those top 3 companies, then go to the 30 suppliers who make the active Bicillin or penicillin G that we're used to. The Bicillin is basically small compared to the other forms of penicillin G, and it's just not profitable. And I know we don't like to hear that in public health because we do so much for so little, but our drug companies, they're looking at their bottom line. In the United States today, The only source of Bicillin is Pfizer. That's it. No other pharmacies in the United States are carrying Bicillin. So when we run into supplies issues, there's no other pharmacists that can step up, or the drug companies that could step up. Pfizer is it. When we're looking at where the shortages fell in up through 2019, I'm pretty sure you can see worldwide, we were not alone. Everybody was feeling it. And one of the big issues is that active pharmaceutical ingredient, or the API lead time, there's no way to shorten that. So when they realized, hey, we need to have more Bicillin, people are coming from it. It wasn't just like, okay, let's just make more. It was, no, we have to wait to get the active pharmaceutical ingredient. And there's no way that that can actually go faster. So looking at, again, who has Bicillin available, as I said, Pfizer is the only American company, but what's really important to see here is how many companies have exited the market. And over the last several years, it's getting smaller and smaller and smaller. But Bicillin isn't only used for syphilis. There's several other things that use it, most notably the treatment for rheumatic heart disease. I recognize that that's not something that we probably see much of here in the United States, but worldwide, there's more than double of the syphilis treatment needed is using the 1.2 million unit dose of Bicillin to treat rheumatic heart disease. So I don't have any great solutions for Bicillin. We're kind of at the whim of Pfizer and the active pharmaceutical ingredient production, but I do think it's one of those things where understanding the history of where it has to come and where it's filled, really important to understand where things are bottlenecked at. So wrapping up, I wanted to talk a little bit about how the Medical Society from New Jersey could help. I'm really looking to help amplify the DoxyPEP message. When I'm looking at 100,000 live births and I need to find 50 who are at risk for congenital syphilis, knowing that half of those cases are not accessing prenatal care, so they're not being tested, I think my best bet is to try to address the haystack, because I'm looking for the needle and I'm not going to find it if I don't try to get the haystack down. So looking at DoxyPEP as a solution to reduce the overall STI circulating, we might be able to prevent and find a few needles and see if we can get our congenital syphilis cases to decrease. I'm also looking for help about amplifying the messaging around Bicillin pricing and working with your local health department. So how do we get the message out to providers to know, hey, if your patient gets hit with a high copay or deductible, here's how we can help you, and here's what we can do. I'd love to collaborate on strategies of how do we get women into prenatal care earlier, get them tested. I think there's a lot of barriers there, especially when we're looking at mental health issues and polysubstance use, of how to get women into prenatal care and engaged. And finally, I would beg for all of this is if you have information from grand round schedulers at your various hospitals that you're associated with, I would love you to share my contact information, because we would love to come and share with them all we know about syphilis and raise the awareness so that our providers are able to do the testing. And with that, I will say thank you very much. I'm here for some questions and your discussion, but I will go ahead for this and stop sharing my screen.
Thank you, Dr. Anschuetz. This was very enlightening. The state number to receive the Bicillin is 609-826-4869. And for after hours, you gave us the email address of Ms. Toby Levin at toby.levin@ doh.nj.gov.
Correct.
This is very valuable information. Now, first, let me ask the audience whether there are any questions.
I see David's hand.
Thank you. So I have a question about DoxyPEP. Since it's a doxycycline, um, it's only a small dose in terms of overall. But if you give it to a pregnant woman, that's not a no-no in real life. So since we're asking people to take it maybe multiple times because every time they have, now obviously it's really for gay men. But if you start broadening it, like you sort of implied, well, maybe they should do it for other people. I think it might be more dangerous for women who are pregnant. I just raised that issue. It's something I was worried about.
It's always something we worry about is doxy getting to pregnant women. And I think that that's definitely a concern to have at play. But I also think, again, looking at how to reduce STI rates, not every woman's pregnant at every time. Even getting it out just to heterosexual men, we know that it takes two to tango, and however we can do to reduce and look at how to reduce STIs. But you are correct. Right now, the recommendations are only for gay men and transgender women.
Thank you, Dr. Campagnolo.
Hi, that was great information. And I have a couple of questions. As a family physician, I didn't hear that you mentioned like really engaging with our family physicians around the state. And I grant you that there's not as many accepting Medicaid patients as we would like because of the poor payment, which is another topic where we're aiming for parity with Medicare payments. But so that was one idea I had, is that I know we have some of us, including Dr. Swee, our president, who are family physicians in this venue, but I would think that would be a good place for you to also at the annual meeting to talk about this. And so I'll pass your name along. And also I was thinking our family medicine residencies are places where we would see the women that you're describing, if they are getting care, often might be, besides the FQHC, in some of the family medicine residencies. So I would encourage you to, I can pass the name along for that as well to my organization, but there's, a number of residencies around the state. So just an idea there. Was wondering about, like, do we look at the siblings of any of these children who, the future babies, because it would seem to me like they're at high risk that maybe they might have gone undetected, and was wondering if that's something that's been thought of at all. So that was one question. The other question was more about, is there any like multi-state activity around figuring out, is there some way to start to make that precursor of Bicillin in this country?
So definitely, I would love to come and talk to all the family medical doctors. I will say, because I'm an STD, pimp me out. I will come and talk to you. I think it's really it's really important to get that message out there about testing, because I think one of the things that I see too, especially with our family medicine doctor, is doctors are being comfortable asking about sex, especially when the patient has grown up with you. I think sometimes it's like, I've actually had a doctor say, but he's a good kid. And I'm like, good kids get STDs too. It doesn't mean they're not a good kid, but we still need to have those conversations. So I think having those conversations to be like, you should be doing annual testing. Here's how to take a good sexual history. Here's what to include. All of those things I don't think get covered well enough. And especially for our residents and our doctors, I'm always there to talk about it. In terms of looking at the siblings of our congenital syphilis cases, and I will say now, because we've talked to all of them, our delivery hospitals in New Jersey, they're testing at delivery. And so I'm not really concerned about the siblings as missed cases. Also, unfortunately, congenital syphilis is brutal, and you will end up in the hospital. We've had 8-month-old babies end up in the hospital, full body rash, failure to thrive. DCP&P is involved because they think the mom is withholding care. And come to find out it's syphilis. And once they treat with Bicillin, the baby starts to thrive, they're putting on weight, everything is good. So unfortunately, untreated syphilis, it's going to be known because that baby's going to have a lot of problems that come up. But also our delivery hospitals, they're testing at delivery, they're finding this stuff. And the last part about the active pharmaceutical ingredient. So I was trying to look through because I had sat through this presentation. Full confession, those are not my slides. CDC put them together and I just found it fascinating. But one of the things that they had shared, and I didn't have it in the slides to really understand it fully, is something about how they make the active pharmaceutical ingredient is basically like that land cannot be used for anything else. It is so toxic. It's like you're out at the Great Salt Lake. And so I don't think there's been a desire to open up that type of plant and have those types of like environmental issues, especially when you look at some of our regulations in the United States. I think that's why it has gone out to other countries. I don't know enough about that to keep, kind of adding more, but I think that's part of the restrictions of where trying to make that. It's not an easy process environmentally. And I think that's why Pfizer probably closed their plant. Because Pfizer was the only one and Wyeth, but they both closed them off when they got consolidation and stuff like that. It's also, they're just really not finding that it's cost effective for them to do because there's not enough in the United States that penicillin is still used to treat for. I always tell everybody, it just fascinates me that syphilis is like our oldest bug, been around forever. Every other bug has figured out how to be resistant to penicillin, except for syphilis, which is good. I can take it. But it is one of those that I'm always just fascinated how the treponeme has been able to hide and just keeps popping up every couple of years.
Thank you.
Thanks so much.
We have another participant, PPSUR.
That's Dr. Orlin.
Please, unmute yourself and ask a question.
Can everybody hear me?
Yep.
Okay, unfortunately, as everybody here knows, through the medical society's Zoom meetings, my video never works. But in any case, I had a question. It was one of your slides we were talking about, I guess, one of the studies from San Francisco, where the word PrEP and PEP showed up on the same slide, which was a little bit confusing, although I do know what PrEP is. So for PrEP, which is basically for men who have sex with men, I guess, that's what it's used for, or primarily, that it's basically PrEP patients are kind of your good patients because they're already doing the PrEP. So it's kind of like a self-selected or selected population. So they're the good patients who take meds, and then will also do the DoxyPEP as well. But does that reflect the real population, or is that a highly selected population already?
Great question. So the study that was done in Seattle and San Francisco was using men who were on PrEP because the PrEP is to prevent HIV. It's one pill a day that you take every day to prevent HIV. But some of the PrEP has some pretty bad kidney side effects. And so you have to see the doctor every 3 months. So the follow-up time for their cohort study was included in their PrEP because they knew they would see that patient every 3 months. They could get a swab for chlamydia and gonorrhea and a blood test for syphilis in order to figure out, okay, how is it working? So it says PrEP because that was their starting cohort of who they went to before they issued their guidelines. But I think the important part here, and I realize I don't have my slides on screen show, but I hope you guys can see them here, is that when they went citywide and said, okay, we're not just focusing on gay men who are taking PrEP and who are coming to the doctor every 3 months. Let's look at what the citywide effect is. And this is when I kind of talk about how do we dress the haystack when we're looking for a needle. They saw that 50% reduction. And so not all of those are gay men who are taking PrEP, but they're seeing it, the effect of that trickle into the community. So I do think that, yes, this is a population that's used to taking a pill every single day. And so telling them, hey, after you've had sex, within 72 hours, please take 2 more pills. They might be a little better than the average population at taking medication. But I think, when I look at DoxyPEP, what I would love to see is that as a provider, again, I'm not one, so you guys, have to tell me what you could and can't do. I would love to see you give a bottle to a patient that has 60 tabs, 100 tabs. You tell me what you feel comfortable with. And tell the patient, when you run out, you need to come back. At that point, I can test you for all the STDs. I can make sure you're good. And then I can refill your prescription from there. Recognizing, like, okay, what if it happens if I see this patient in 2 months and I gave him 60 tabs? That means that there were 30 unprotected sex acts in the last 2 months. Maybe I want to talk to them about PrEP and preventing HIV because that could have been an issue. Or if I don't see them for a full year and they tell me I still have half a bottle, okay, let's do some routine checkups and let's make sure you're still keeping yourself safe. So I think, it's probably the best tool we have in our toolkit right now, because unfortunately condoms are just not popular. People are not using them. They have all their reasons for not using them, whether they don't like the feel, it kills the mood, whatever else. We're just not seeing, we've been seeing our rates go up, up, up and away. And just telling people to come in and get tested hasn't been working. So I'd really like to see, what does DoxyPEP add to the story? And how can we start to see, with a biomedical intervention, which HIV now has had for several years, and we start to see those cases go down, could that also get our STD cases down? Because one of the main goals of the health department is ending the HIV epidemic, which it's possible with our biomedical interventions, but we're not going to end the HIV epidemic if we have an epidemic of STIs going on. They have to be addressed simultaneously. Otherwise, people will still continue to be exposed.
Thank you.
Dear Dr. Anschuetz, I then realized that we have 3 problems. One, the problem of awareness, and you have clearly shown that syphilis is on the upswing. The second is avenues of training. And the third is actions that MSNJ can take to address both DoxyPEP and Bicillin availability. Perhaps I invite our management team to comment on that, and I suggest that we need to review this in our next executive committee meeting.
Can I just, sorry, I don't know how to raise my hand. I'll have to do just, hi Greta. So I'm Gregory Hirsch. I'm Chief Medical Officer of Planned Parenthood, Northern Central and Southern New Jersey. And I just, we've been doing obviously, well, not obviously, PrEP for years now. But we started DoxyPEP maybe 2 years ago or so. So we do, I don't know, a fair amount of DoxyPEP. We see, and we, since, really around the time of COVID, we really started treating syphilis. And so I just, I'll put it out there that we, if anyone comes, if people need to be treatment for syphilis, because I think private practitioners don't know how to, they can't get a hand on the Bicillin, Bicillin, right?
Bicillin.
Anyway.
Bicillin is easier. Just go with Bicillin.
And to give it, but anyone can come into a Planned Parenthood and say, I was diagnosed with syphilis. We don't require a test. We don't require, you just have to say, I was diagnosed and I need treatment, and we will treat them. We'll follow them up. We'll follow their titers. So I just put that out there as a resource. We have a number of clinics, 17 clinics around New Jersey. And also we're available for PrEP and PEP, for PrEP and PEP and DoxyPEP.
And I would also plug that as another great resource, as Dr. Hirsch said, is the Planned Parenthood of Southern New Jersey is under the New Jersey Family Planning League, which receives money from the New Jersey Department of Health STD program. Because they do that, we are able to confer our 340B eligibility. So Dr. Hirsch is able to buy the Bicillin at the cost that I am paying now and make that available to his patients. So that's something that's very important, is understanding where these networks are, because I think because you have so many agencies and our family planning network covers every single county in New Jersey, it's a great resource to be aware of where to refer patients to if they're getting hit with a high dose, a high copay that they just are never going to be able to afford.
Right. Right. And I'll also say, I think a lot of people, it's easy to test for syphilis. But I think a lot of doctors don't want to treat for syphilis. So I just put it out there, resource. We don't turn anyone away for cost. And when we're not in a shortage, we're happy to treat anybody.
And I would also say a lot of our providers and clinicians are not used to how to interpret syphilis results as well. You get a titer. What does the titer mean? What does this have to do? How do I have to do this? I have a great case example of, I had a person come in, 1-to-1 titer, TPPA positive. We called the provider and said, did you treat? And the provider said, no, it's just a 1-to-1. Like, what? This is a PrEP patient. They were negative 3 months ago. Now they're 1-to-1 with the TPPA reactive. Are you aware? And they said, no, it's fine. It's just, 1-to-1 equals negative. And we're like, no. And then we're trying, as non-clinicians, to educate the clinician. We convince them to bring the patient back in and retest. Patient comes in, full body rash, redraw of the RPR, 1-to-64 secondary syphilis. And so some of these case examples, you look at the fact that we have a whole group of clinicians coming out who have never seen a syphilis case. It was very, much more common in the 80s and the 90s when we had our crack cocaine epidemic, and a lot of our clinicians saw syphilis. They think it's gone. And so how to raise that awareness, and I always tell everybody, this is what your health department is here for. I touch every single syphilis case pretty much in the state of New Jersey. Before this, the city of Philadelphia. And when people would say, well, how do you know to tell me like this is the treatment guidelines and what I should do? And I said, I've seen it all. I consider myself a syphologist, because back in the day, that's what I would have been called. And this is what is going to need to happen for this patient. And I think knowing that you can call the health department and consult, and that they're going to know what they're talking about, I think that's also an important message to be sharing out there, and saying we don't expect you to know everything and every interpretation of lab results. It's a lot, but this is a hard one for people sometimes to understand. Also to understand that the state health department, that same number that I had in the slide for Bicillin, we can also do syphilis record searches. The oldest one I found was a woman treated in 1947. I was shocked. I found her, but I have her treatment in 1947, and she was being worked up for a dementia workup. And I was like, it's not syphilis because she was adequately treated. And here's her whole history of titers. So again, resources that your health department are here for. I think these are also good things to say. How do we increase this message so that people are calling us and asking us and what's going on? So I saw Barry was next, and then Larry, your hand is up.
Thanks, Greta. I appreciate you coming in. I just wanted to emphasize that when you treat after birth, sometimes I have a patient in and out of the hospital every week with difficulty, obstructive breathing that snuffles the airway. The kid's been scoped by pulmonology, ENT, and we can't get the kid to breathe and eat. And it's just an uphill battle. So thank you. We really got to get it before they're born.
Mm-hmm. Yep.
Thanks.
Anything we can do.
Thanks so much for your talk tonight. One thing, just from the staff perspective at the Medical Society, one thing that we'll typically get questions on would be if a fully insured patient came in, saw physician. They wrote a script for something and it came back at $1,500, and the patient, the patient was then, non-compliant, as you mentioned. That would be a situation where we might get a call. So I think the resource of having, a local health department or the consortium that was mentioned as a treatment alternative to refer that patient to would be really, really profoundly helpful to our members, because they're always battling insurance coverage and deductibles and high cost of what should be relatively straightforward antibiotics. But in this case, that's a great resource, and I think we can put together a resource page on our website to help people navigate that, and other resources that are in your talk. So that's a great opportunity for us to get that information out to the field.
And I just put into the chat, we do publish the local health departments. If you're not familiar with the local public health landscape of New Jersey, yes, we have 21 counties, but we have 106 local health departments. And how they divide up is not always the easiest for physicians to navigate. Especially though with syphilis, I also usually would recommend call us, only because our version of the system sees the whole state, where we can give you that true history. Our local health departments could only see their residents. And if you've moved from East Orange to Irvington to Newark, you're not going to see that complete picture unless you request it from the state. But it is important, I think, as the New Jersey Medical Society, to make sure their clinicians are aware of who is your local health department. And this goes based on the patient's address. So, if you're seeing somebody from Elizabeth, I open up this document, I copy and paste Elizabeth, find it, and say, okay, now I know who the health officer to call, to email, and to say, hey, I need help with this. And then this is way beyond syphilis. You think about earlier last year, we were having measles circulating. What do? You're supposed to call. Oh my gosh, who do I call? Knowing where to find your local health department, I think, is really important when you see those emergent cases that you need to pick up the phone and call.